Good morning. This is Dr. John Bennett in Miami Beach for another Neurosurgical Super Sunday. I'm Cherian, MD, who was scheduled to give the first talk, had an emergency cystinostomy. So we're moving on with Dr. Rakesh from Kolkata, India. He's going to present a paper that he just won a prize for. At a conference in Istanbul, and he's going to tell us a little bit about that. But first, let's meet the panelists before we turn it over to Rakesh. Amira, could you please introduce yourself? Amira, could you please unmute there? And you're muted, Amira. Okay. Introduce yourself. Yeah, we can hear you now.
Okay. My name is Amr. I'm from Ukraine. I'm Jordanian. I'm a neurosurgeon.
Very good. Well, welcome, Amir. And Juma, welcome.
Yes, hello, everyone. I'm Dr. Juma. I'm from Tanzania, originally from Tanzania, but I'm doing my fellowship in India.
Very good. And it looks like you're using your iPhone, a portable hangout.
Of course.
Well, that's excellent. And hello, Slaven.
Hello, my name is Slaven. I'm from Zagreb, and I'm really looking forward for this talk from my good friend Rakesh. Thank you.
Yeah, Slaven's like Rakesh, an old timer, and welcome. And I'm John Bennett again from Miami. Okay, Rakesh, it's all yours, and welcome.
Good evening, everyone. Good evening from India, and thank you so much for being in the panel, Mr. Amar, Juma, Slaven, and Dr. John. As already introduced, I'm Dr. Rakesh AV from India, and I'm doing my neurosurgery residency at Kolkata. I will be presenting on Cauda Equina syndrome, which I recently presented in one of the international conferences in Turkey, Istanbul. Yeah. Okay, Dr. John, are you able to see this?
Yes, excellent.
Yeah. Okay. Okay, once again, good evening, everyone. I'll be presenting on Cauda Equina syndrome. First of all, greetings from India. This is a well-known Taj Mahal. And greetings from my home place where I do my neurosurgery residency. This is one of the beautiful memorial, Victoria Memorial at Kolkata, India. It's just behind my hospital. And this is where I come from, the hospital where I do my residency. Today, I'll be presenting on Cauda Equina syndrome, and I'll be doing this on the following headings. As you all know, Cauda equina are the group of nerve roots that arise from the culmination of the spinal cord, that is the conus medullaris, which ends at L1 of the spinal level. There are 9. These are the 9 pair of nerve roots, starting from L2 and extending till S5 and including it. These form what is called Cauda equina. Cauda equina syndrome is a severe neurological disorder that was first described by Mixter and Barr in 1934. This disorder is caused by any entity that causes pressure upon the Cauda equina, these 9 pair of nerve roots. And whenever there is a pressure on 2 or more nerve roots, this leads to a syndrome called Cauda equina syndrome. This is the diagram showing Cauda equina. It extends from L2. Where you can see the.
I'm very sorry. The slides are not moving.
Yeah, the slides are not moving
in your presentation. I'm very sorry to interrupt.
Yeah, thanks, Slaven.
Maybe if you can.
Yeah, me too. I can see the slide.
Now we can.
And, now you can see the slide which is showing Cauda equina figure.
Yes, now you can see.
Yes.
Is it moving now? Is it moving now?
Yeah.
Epidemiology causes. Yep.
Okay, sorry.
From the beginning, if you don't mind. Yeah.
Okay, sorry for the interruption. As you can see in the figure, the Cauda equina extends from L2 vertebra and extends down, and this is the level at which the conus medullaris ends, at the lower border of L1. Here, as you can see it, and this is what forms a Cauda equina, the 9 pair of nerve roots of L2 to S5. Can you all see this?
Yes,
Hello?
we can. Yes, we can.
Okay,
Yes,
is it moving now? Can you see the epidemiology?
Yeah, epidemiology.
Yeah, the incidence of Cauda equina syndrome is estimated to be 1.2% to 6%. it's of the of all the low back pain patients, but it ranges from 1 in 33,000 to 1 in 1 lakh of all the normal population. However, the actual occurrence of Cauda equina syndrome is difficult to estimate because there is no a single universally accepted clinical definition for Cauda equina syndrome. This is how it makes difficult to know how much exactly, how many patients are suffering from Cauda equina syndrome at a given point of time. Coming to the various causes of Cauda equina syndrome, the most common cause is lumbar disc herniation. And the most common area where the disc herniation causes Cauda equina syndrome is between L3 to S5 levels. There are various other causes which causes Cauda equina syndrome, which is a result of the compression of the nerve roots at this region extending from L2 to S5. There are various reasons like vascular arteriovenous malformation in this region or hemorrhage of any kind in this region, and there are various inflammatory conditions that causes Cauda equina syndrome, and the most common is ankylosing spondylitis. And there might be neoplastic conditions which are causing pressure on the Cauda equina that might be primary. The most common myxopapillary ependymomas in this region or the metastasis METs in this region can cause Cauda equina syndrome. A bacterial epidural abscess or the tubercular abscess causing pressure on the Cauda equina, or congenital causes like congenital spinal stenosis or spinal dysraphism or spinal fracture and dislocation in this region can cause Cauda equina syndrome. And the most important entity which is not mentioned in this list is after surgery. Post surgery, there might be an epidural hematoma in this region or epidural fat graft that has been left can cause pressure on the Cauda equina and cause Cauda equina syndrome. This is the extensive list showing the various causes of Cauda equina syndrome. As I have already mentioned, the most common cause is the disc herniation at this level. The other causes being vascular, which I've already mentioned. There were other various rare causes which this list gives extensively. I don't want to go in detail of all these cases because there are a lot of case reports that have been described. But in all these cases, the most common mechanism that causes Cauda equina syndrome is the compression of the nerve roots, as you can see in this MRI picture. Can you all see this? Hello?
Yes, we can see it.
Yes, we can see it.
This is the compression you can see. This is a common mechanism, common pathophysiology in all the causes which I listed, which causes Cauda equina syndrome. Coming to the pathophysiology, what causes the Cauda equina syndrome? Whenever there is a pressure, there is a mechanical or ischemic compromise in this region, which physically deforms and disturbs the microcirculation of the nerve fibers, leading to ischemia and formation of intraneural edema in this region. And this causes the Cauda equina syndrome, the dying of the nerve roots at this region. This is partly also attributed to the poorly developed epineurum in this region, which causes less protection from the outside stresses or tension and hence leads to Cauda equina syndrome. Clinical presentation is variable depending upon the level and location of the disc herniation, which is the most common cause of Cauda equina syndrome, as well as the individual patient characteristics. Cauda equina syndrome can mimic the most common lumbar spondylosis, which presents with low back pain with radiculopathy. However, how do you differentiate between a lumbar spondylosis and a Cauda equina syndrome in these two symptoms? Whenever you have a patient with a severe back pain, he says that I have a severe low back pain, but he doesn't have much of radiating type of pain, then you can suspect Cauda equina syndrome in this patient, along with this other symptoms which I'll be telling. Coming to onset, the onset of Cauda equina syndrome is most commonly acute, and these patients have a prior history of low back pain, and a patient with a prior history of low back pain comes to you with the acute onset of severe low back pain. That should make you suspect the Cauda equina syndrome. There might be some patients who have no prior history of low back pain, and these patients may present with acute presentation also. This forms a less percentage of patient. A very lesser and rare kind of presentation is chronic presentation, in which there is an insidious type of onset and progression of symptoms. And you have to remember, in such cases, there is a better chance of recovery from a bladder dysfunction, which happens in Cauda equina syndrome. So what is the most common presentation of Cauda equina syndrome? Most common presentation is a young male around 30 to 40 years of age. He comes with a prior history of low back pain. He was not operated on. He was just taking medications, and he presents with a severe low back pain with other symptoms, which I'll be telling you. This slide is showing the most common level of involvement, L4, L5 being the most common level. So whenever there is a disc hernia, whenever the patient presents with a low back pain and radiculopathy, you need to examine the patient with respect to motor system, sensory system, and reflexes to know which nerve root is involved. As shown in this figure, whenever there is a disc herniation at the level of L3, L4 nerve root is involved, and you have to know what is the motor function, reflex, what is the reflex controlled by L4, and what is the sensory area of L4. This figure shows what the motor dysfunction due to L4 radiculopathy, and the reflexes what are lost, and the sensory system which is lost. So this is the knowledge that the clinician should have, if what are the nerve root distribution with respect to motor, sensory, and reflexes. These four coming slides show the same thing. Whenever there is a L4 and L5 disc herniation, L5 nerve root is involved, and the clinician should know the motor, reflexes, and the sensory system that is supplied by L5 nerve root. And this gives us the clue as to where the disc herniation is there and where the problem is there. And this is L5S1, in which the S1 nerve root is involved, and this is the figure showing motor, sensory, and reflex of S1 distribution. Again, coming to the important points in Cauda Equina syndrome. The most important thing, sensory disturbance that is observed in Cauda Equina syndrome is a saddle anesthesia. This is the saddle area, the distribution from S2 to S4 nerve roots. And 75% of the patients with Cauda Equina syndrome have saddle anesthesia. The patient can't feel the sensation in this area. And whenever you have to ask the leading question, the clinician has to ask the leading question of if the patient has the perianal anesthesia, that is the saddle anesthesia, and this will lead to the suspicion of Cauda Equina syndrome. Coming to the motor system examination, in these patients, motor weakness can be severe and involves, as told, more than a single nerve root at the Cauda Equina. And it may be bilateral or unilateral, but whenever it is bilateral, the unique feature of Cauda Equina syndrome is asymmetric. That is, one side has symptoms more than the other. And whenever these patients are not treated on urgent or emergency basis, which I'll be coming to, which is an interesting part of the treatment, which I'll be coming to in the next slides. If they are not treated urgently or emergency, then it might lead to permanent disability and permanent bladder and bowel dysfunction. This is the most important slide of my presentation. That is, what are the red flag signs in these patients who we suspect of Cauda Equina syndrome? A patient comes and you are taking the history, and you come to know that the patient with the low back pain with the disc herniation has these symptoms, then this is an emergency case which you have to operate. The red flag signs which you have to ponder on is urinary disturbance, that is urinary retention, which is seen in up to 90% of the patients with Cauda Equina syndrome. Whenever there is a signs of urinary retention, you have to check the post-void residual. If it is more than 100 ml, if the post-void residue is more than 100 ml, then it suggests that the patient has Cauda Equina syndrome. Patient also may present with overt overflow incontinence, that is the complete urinary retention and overflow incontinence. That is the end stage of symptoms of Cauda Equina syndrome. The other red flag sign is the loss of anal sphincter tone, that it is diminished in these patients, and it is seen in up to 75% of the patients. And the third red flag sign is the sexual disturbance. The patient says there's impotence, and in male patients there is absence of morning erections. These are all the history points which you have to ponder on, and you will come to know that the patient has red flags. So the most important thing in Cauda Equina syndrome diagnosis is good history and physical examination of these patients. You have to ask all these questions regarding his urinary problems, the anal sphincter tone, and the saddle anesthesia, and any sexual disturbances. These are the four most important things you have to take in the history and physical examination. Coming to the classification, for the treatment purpose and for the purpose of severity of these patients, and for the purpose of prognosis, it has the Cauda equina syndrome has been classified into 3 types, that is early, incomplete, and complete. What are the definitions of these early, incomplete, and complete? This is the table showing the definition of 3 classification of Cauda equina syndrome. As you can see, early Cauda equina syndrome are those patients who just have progressive radiculopathy in the lower extremities along with low back pain, and they don't have any urinary disturbance or the anal sphincter tone disturbance or any sexual disturbance. These patients come under early Cauda equina syndrome. And then comes 2 other categories, incomplete and incomplete. It's simply that if the patient has just urinary difficulties but not frank retention, it goes into incomplete. If the patient has complete urinary retention, then it goes into complete Cauda equina syndrome. So what are the urinary difficulties? It might be diminished in the initial stages, diminished urinary sensation, loss of desire to void, or poor urinary stream. These are all the symptoms of incomplete urinary involvement. And when it goes to complete urine retention, there might be overflow incontinence. This is when you say the patient has complete Cauda equina syndrome. The nerves have already died in the complete Cauda equina syndrome, and the nerves are dying in incomplete Cauda equina syndrome, where you have to emergently operate. Otherwise, the patient will end up in dying of all these nerves, where you can't help, and the patient has to live with these symptoms lifelong. This is where it makes the most important of classifying the Cauda equina syndrome and going on right treatment at the right time. So what is the investigation? Well, investigations in MRI is the method of investigation of choice. And remember, we go with MRI at the early stage because there is a very low sensitivity of this clinical assessment because of variable presentation. What I mean to say is you can't diagnose Cauda equina syndrome easily with the clinical history and physical examination. So you take help of MRI investigation early, and you see what is the condition of the disc there. And this is very important that you go with the MRI early and not wait. If MRI is contraindicated for any reasons, like the patient is on pacemaker, then you can go for CT myelography, which is also a very good modality and can easily diagnose these cases. These are the images showing the CT, where you can see a small canal here. It's already, the disc is compressing the nerve root so much that you can sometimes it's almost not seen. In this, you can see a small canal. And this is the MRI images. This is the axial, and this is the sagittal section. This also you can see the white thing. That is the space left, and this all thing is the disc. This is a whole disc. This is herniated here. This is where when there is a large central disc herniation, you suspect Cauda equina syndrome. There's a large central disc herniation. The nerve roots are compressed here. That is when from the image you can say this patient can go to Cauda equina syndrome. I need to ask him about his urinary symptoms and the anal symptoms and the sexual disturbances. So the key is the large disc herniation, which I'm mentioning now. So coming to the diagnosis, this is, as I said, there is no single perfect definition for Cauda equina syndrome, but this is how it comes to the last. If a patient has a large, I repeat, large central disc herniation, and along with that he has the bowel and bladder dysfunction in the form of urinary disturbance or retention, and the loss of anal tone, which you check by digital examination, or the patient has saddle anesthesia, which I showed, or the sexual disturbance, any one of these, along with large central disc herniation, the patient is said to have Cauda equina syndrome. Coming to the most important part of my discussion, that is management. It's really very important for the neurosurgeons. Cauda equina syndrome. This Cauda equina syndrome is one emergency spinal disease where the clinicians, neurosurgeons should be very aware of. Otherwise, they will end up in medical legal cases, which I'm going to come in the future slides. This slide shows Nicholas Todd, who is a pioneer in Cauda equina syndrome. He has many books on Cauda equina syndrome and many articles on Cauda equina syndrome. And this is one article, a very important and a standard article for Cauda equina syndrome, which was published on 30th May 2016 in one of the standard journals, that is British Journal of Neurosurgery. The title is the Standards of Care in Cauda equina syndrome. If you guys want to know more about Cauda equina syndrome, this article you should have. This is a paid article. I have this article. If anyone of you wants this, I'm very happy to share. So yeah, this is I want you guys to concentrate on. This is one of the crowded slide, I agree, but this is the most important slide with which shows the Cauda Equina syndrome management. So I want you to concentrate on these slides. The first one is just a low back patient, a regular low back patient. This is not the Cauda Equina syndrome. This is just has been mentioned here. No need to concentrate on this. This is a low back patient. Just give him analgesia, reassure, and follow him up. Coming to the Cauda Equina syndrome popper, whenever you see a large central PLID, large central disc herniation, and the patient has radiculopathy, then comes a suspicion of low Cauda Equina syndrome, and this is categorized as low risk Cauda Equina syndrome. You just manage him like a patient with the low back pain syndrome with radiculopathy, give him analgesics and the support to the lower spine and some of the physiotherapy, and follow him up. But you have to tell him about, warn him about the red flag signs which I just showed. That is about you have to tell the patient, if you have any of these red flag signs, then you have to immediately come. The patient has to immediately come, and the patient has to be operated immediately. Otherwise he will lose his bowel and bladder function, and he will live with it whole life. This is why it is red flag is most important, and this is why even for this patient you have to warn. Tell him that if you have any urinary disturbance, any disturbance in the perisaddle area anesthesia, or any bowel incontinence, or any disturbance in sexual function, then please immediately come to us. So this is very important. Then comes other patients who have large central disc herniation and bilateral radiculopathy. Then you need to admit this patient. You need to admit this patient because you know this patient can deteriorate anytime. Deteriorate in the sense, anytime this patient can have the urinary symptoms or the this anal symptoms, bowel disturbance, where you have to immediately operate. Otherwise the patient will lose it. So admit this patient, keep the patient under observation. The options you have is operate or wait and watch. If you're operating this patient, if you plan to operate this patient, then you can put in the acute list. What is acute list? What is acute list and what is emergency list? I have a separate list, a separate slide on this which explains this. But now, as of now, I'll be telling that acute list is you can operate the patient on the next morning, but emergency list is you should operate immediately within hours, day or night. Okay, I'll be explaining you in detail about this. Next patients are large central disc herniation with urinary symptoms. The CSEI means Cauda Equina syndrome incomplete, which I showed. The patient has urinary symptoms only. This patient is under your emergency list. You are going to operate within hours for this patient. Otherwise, you are going to make the patient lose his bowel and bladder functions for his life. You have to emergently decompress it so the dying nerves will again survive and he can have some of his function back. Then other function, the large central PID with based on the history, you are uncertain if the patient has symptoms or the patient has already gone into complete retention. In such patients, you again make a test of if the patient has the residual sacral nerve function. If the patient still has some function, then again it is an emergency. There is some function. If you don't operate, he will land up in complete loss. So you have to, it comes under incomplete, and again you have to go into the emergency list. If the patient has complete loss of this, then you can go on the acute list. That is tomorrow you can operate because there is nothing to lose. The patient has already lost, but you have to operate on the next day morning. So this is the last one where there is a large central PID and the patient has completely lost. It comes under the complete Cauda Equina syndrome, and this has to be in your next day acute list, and next day you can operate. This is a very comprehensive table. This is a very comprehensive and beautiful table. I liked it a lot, and this is present in this journal. So if you people want to see it, I can share with you. And what is all about the surgical issues in Cauda Equina syndrome? I was telling emergency, urgent, emergency, urgent. The most important thing in Cauda Equina syndrome is timing of surgery. Very important, very important. And you will come to know by the end of this thing why it is so important. What is emergency? What is urgent treatment in Cauda Equina syndrome? Emergency is, by emergency I mean it has to be operated immediately. By acute I mean that it has to be operated by the next morning. This what is I have already explained you this in that type of list. Emergency comes which is deteriorating. The nerves are dying, but it is not dead. The nerves are dying, the incomplete one, or where you are uncertain, that is incomplete. What comes in the acute list? the low risk Cauda Equina syndrome, where you can operate or not operate. If the clinician decides to operate, then yeah, it comes in the acute list. You can operate in the next. But there is other cases where there is a complete loss of the function, then it comes in the acute urgent list. So this is where I was telling you why is Cauda Equina syndrome most important. There have been several medico-legal cases. If you can Google it, you will see there, and the huge compensation the doctor, the clinician had to pay because he missed the diagnosis. He missed the diagnosis because there is a very variable presentation of Cauda Equina syndrome. He missed the presentation because the symptoms are so variable that you always tend to, most of the times, you tend to miss this diagnosis. So there were cases where the patient was in the incomplete stage, where if operated he would have gone into he would have saved his bowel function, but no, the clinician missed it, and the patient went into complete loss of Cauda Equina syndrome, and he lost all his bowel and bladder function, and he went to the law, and the doctor had to pay the huge amount of compensation. Can you see, this is 300 million euros. 300 million. There are these many lists. This is just a list. If you can see in the Google Cauda Equina syndrome and the compensation paid, this is where Cauda Equina is so important. So prompt recognition and treatment of patients with Cauda Equina syndrome is imperative to both to patients and doctors. For patients, it is to avoid permanent debilitating neurological deficit associated with it and the socio-economic burden which it causes. For doctors, it is most important because to avoid the medico-legal consequences related to the delayed diagnosis and management. To conclude, Cauda Equina syndrome, as I said, has a variable presentation and is widely thought to be regularly misdiagnosed and just plainly missed. Physicians must maintain a high index of suspicion whenever there is a large disc herniation along with urinary symptoms, perianal anesthesia, or the anal incontinence. Rapid radiological evaluation, what I said, immediate MRI has to be done for this patient if CS is confirmed. Surgical spinal decompression should be performed on emergency or urgent basis. Failure to recognize the syndrome, especially in emergency setting, is an ongoing issue subject to continued litigation, that is medical legal cases I just showed. This is a paper showing which just studied the life of a patients who have been victims of Cauda Equina syndrome. The title of this article is "The Lived Experience of Cauda Equina Syndrome: A Qualitative Analysis." In these, the semi-structured interviews to investigate the lived experience of Cauda Equina syndrome was done, and the conclusion was there is a lot of importance for improving the access of support for these Cauda Equina syndrome patients, for these patients to support to live with the various neurological deficits they had to undergo. And there is a very much important for the psychological impact what this Cauda Equina syndrome has on the patient's psychosocial impact on patients' lives. So this is a very interesting book. When I was doing my research on Cauda Equina syndrome, when I got interest in this, I came across the book in which Cheryl Saucer Wilson, the author, writes about his own wife who is the victim of Cauda Equina syndrome. And in this, being a layman, he also stresses on time, which is most important. Time is of essence in Cauda Equina syndrome intervention. I was so interested in Cauda Equina syndrome and going to do my research in this, that I was seeing all the foundations which help the Cauda Equina patients, and I came across one of the foundation where it serves to improve the quality of the life and care of these patients with Cauda Equina syndrome. And I happened to talk with the CEO of this foundation, Ms. Amanda, and mind you, she herself is a Cauda Equina patient, and because of her life leading with so many symptoms, she managed to open a foundation which helps the people who are suffering like her. So this is in this picture she is showing shoes which is made in Cauda Equina syndrome. There might be foot drop might be one of the symptom, and the patient might have to live with it for whole life. to avoid this, there are some of the equipments that have come, and she's showing a shoes which has a sensor. She's showing the sensor. The sensor, it senses whenever we are in the different phases of our stance, and there is a other sensor which will be in the knee, and whenever there is a foot drop, it senses and it avoids from the foot being dropped. And this is how, where there are various equipments, various foundations, they are investing in Cauda Equina patients care, and coming out with many equipments that helps patients with Cauda Equina syndrome. And I'm happy to say that I am a member of this foundation now, and I'm in the education team. And thank you so much. This is the photo showing me with the world spine hero, that is Professor Dr. Mehmet Zaleli, and I am receiving an award for the same presentation I presented in one of the international presentation. I'm so happy to be a part of Neurosurgical TV from the beginning, along with Dr. John, Mr. Dr. Slaven, Dr. Simon, and many others, Dr. Aibchirin, and many others involved in this. Sorry, I have missed some of the names, but I'm very glad. This is a very good platform, Neurosurgical TV. I'm very glad that I'm a part of this. Thank you so much, everyone who has attended this. Thank you.
Thank you.
Thank you very much, Rakesh. Can you please get off the screen share to see you? This was really an amazing presentation. Indebted to you for sharing this experience, and the award. You didn't boast much about the award. There were 2 awards recently that you received for your presentations, and can you tell us something about this?
Yes, thank you so much. Yeah, thank you. Yeah, I have the photos. Thank you so much for mentioning that. Yeah, recently I've been lucky, and because of God's grace, recently 2 presentations, one in National Neurosurgical Conference and one in International Spine Conference. I was lucky, with God's grace. I have got best presentation in both the presentations. Okay, since Slaven has told, I would just like to share some of it. So yeah, I'm not finding the photos. Yeah, I'm not finding the photos. One of the presentation I did in All India was my paper on traumatic brain injury, in which I was seeing the genetic makeup that is brain derived neurotropic factor. I will be presenting in one of the Neurosurgical TV conferences that my paper is on BDNF, brain derived neurotropic factor polymorphism, that is valine and methionine, and how it affects the traumatic brain injury patients, mild and moderate. So this I presented in one of in the Indian National Neurosurgical Conference, and I was awarded best paper for that. And this is International Basic Neurosurgery Conference, where I presented the same paper, Cauda Equina Syndrome, which I just presented. And there I got, and there were other few presenters from different countries, from Pakistan, Turkey, and Iraq. And there were students, around 250 students from various different countries who had attended that conference. It's a big conference that happens, I think, since many years, 10-15 years. And I was lucky that I was awarded there with the best presentation. Thank you so much. Thank you so much for asking.
That's really a wow, and really congratulate you to cordially, all of us at the panel and at the Neurosurgical TV. So I would really like to get the articles you mentioned. So if you have somehow or some links, we would be very.
That was a paid article.
And now I would like to open.
I took it, and I will be sharing with you. I will be sharing with you immediately through your email ID. Yeah, tell me.
Thank you very much. I would like to open the discussion if there are any comments. Maybe Dr. Amer, you have some comments?
Yes, I have one question. You listen to me? Yeah?
Mm-hmm.
Yes, I can hear you. I can hear you, Dr. Amer.
Mr. Rakesh, tell me, Cauda Equina syndrome, maybe after falling after lumbar puncture.
Yes. So I showed you a extensive list, if you can remember that slide, which I didn't go. So there are various case reports. There are various case reports, interesting case reports. When you put up a spinal needle, there are case reports when you put a spinal needle and you are doing some CSF examination, and that causes a bleeding, a epidural hematoma there, and that hematoma causes the pressure on the cauda equina nerve roots, and that causes cauda equina syndrome. Yeah, though, so there are even the spinal procedures causes. So the list is extensive. The list is extensive.
Thank you very much.
Great. Dr. Juma, please go ahead if you have any comments or remarks.
Okay, I have an opinion and I have a question. Regarding timing in spine surgery. I think there is still a controversy in most cases, as some do say you can operate within 24 hours, some say you can delay up to 48 hours. But you have shown for us a list where you can intervene as an acute or as an emergent. But I think for me, it looks like it depends on the cause as well. If the cause is an abscess, say it's an abscess, or the cause is ischemic, even if you rush for surgery, there will be no difference in outcome, even if you go early or you intervene late. So this is my opinion that timing in surgery, okay, timing in a Cauda Equina syndrome also depends on the cause of the inflicting agent. I mean, like if it's ischemic reason, then it won't change any outcome. Another thing is sexual dysfunction. How many cases do they present with sexual dysfunction, and how do you manage these cases? Because sexual life life is very important to many people. How do you manage, and how is there any good outcome or good follow-up for this patient?
Yeah, coming to your further, you made 2 points on this. The first one I'll answer one by one. The first one, you said that the timing of surgery, according to your opinion, depends on the cause of the Cauda equina syndrome. See, as I in one of my slides I showed you, whatever might be the cause of Cauda equina syndrome, the mechanism is the same. The ischemia, the reason for Cauda equina syndrome is ischemia. It's not like some causes cause ischemia and other causes doesn't cause ischemia. It's not like that. Whatever causes I listed, or whatever causes Cauda equina syndrome, in turn will lead to ischemia of nerves, and this ischemia will cause the dying of the nerves, and that will lead to Cauda equina syndrome. So according to me, I have made whatever you told about the timing of surgery. There was a lot of controversy about 24 hours, 48 hours, and the article I showed you is a recent article, and that article is by one of the pioneers in Cauda equina syndrome, and that has been done after seeing all the various articles. They have come to the final conclusion that what is the final timing of surgery, the opinion on timing of surgery. So as of ischemia is concerned, all of these causes finally lead to ischemia, and that lead to Cauda equina syndrome. So according to my opinion and my analysis of all these, whatever may be the Cauda equina syndrome cause, it has to be operated. It has to be operated based on emergency or urgent, as whatever it is classified, and it doesn't depend upon the cause. The timing of surgery doesn't depend upon cause. Like this cause, if it is this cause, you will not operate fast. This cause, you will operate fast. It is not like whatever the cause. If it is a Cauda equina syndrome and it comes under incomplete, then you are going emergency. If it is complete, then you are going on the next day morning. This is what is my conclusion. Coming to the second one, the sexual disturbance. To be frank, I actually don't have a follow-up of sexual disturbance. But what the books mention is around, I think, I'm not sure about this also, but 30 to 50%. And again, if what about the recovery of these patients, you asked? If it is incomplete, and if you act emergently in these patients, there are around 30 to 50% chances of recovering of these patients, these sexual disturbance cases. And if it is already complete, then it is lost. And what about their next life, the further life with the loss of sexual dysfunction? I haven't had much research and much study on this. I have to see this. Pardon me that I have not gone to the literature about the sexual disturbance much.
Okay, thank you.
Thank you so much. Thank you so much for the question.
Okay, Dr. Bennett has a question himself, so I would like to give him the possibility to ask. Dr. Bennett,
Yes,
are you
thank
ready?
you, Slaven. Thank you for hosting, and thank both you and Rakesh have been with us from the very beginning of Neurosurgical TV. It enables us to bring neurosurgeons like Amir, Juma, and Rakesh together on a platform. One thing I noticed, Rakesh, did you have a hangout with the head of the Cauda Aquinas Syndrome? Because I
Yes,
saw,
yes,
saw a
I had.
picture.
Yes, yes, I had a hangout with her. I had a discussion, 45 minutes, 1 hour long, and I'm lucky to be a part. She made me a part of Cauda Equina education team, and she herself is a Cauda Equina patient. She herself is a Cauda Equina patient, and the shoes she was showing, she herself wears it to avoid a foot drop. And she uses catheter. She is catheterized because she was a victim who was not operated emergently, and which led to who was not operated on the right time, and which led to lifelong symptoms. She knows what is the life of Cauda Equina syndrome, which that's why she has made a foundation, and there are around 200 patients who are benefiting from this foundation. And uh, and a very good foundation. I was very happy with this type of foundation, and I'm actively contributing my contribution to that foundation.
Well, let me just offer her our help because we can use this technology of Hangouts
Hmm.
for a foundation like hers,
Yes,
where she can communicate with Cauda Equina patients around the world. All you need is an internet connection. I mean,
yes, yes,
obviously, a group like that cannot get together in a room because they're all over the place. But the internet goes every place, and we could use it like you and I have used it to get people together on the screen to educate.
I forgot. I actually wanted her to invite today. Some of this thing. I'll invite her once to our platform. We can have a discussion. I think that will be best.
Yes, sure. She can give a talk on neurosurgical TV. She wants to tell us about her foundation, and she can invite other people. But this is the benefit of this type of platform.
Yes, thank you so much. Thank you, you and Slaven and all others who have been the base of this. Thank you so much. This Universal Surgical TV is more of a help. It's more of a selfless platform which is helping a millions, I think, thousands of neurosurgeons as of now around the world. So I'm thankful to you both and all the team members who are working constantly for it. Thank you so much.
Okay, I'll let Slavan close.
Well,
He's hosting today.
Yeah.
thank you very much, Dr. Bennett. Well, I have really been moved with what Rakesh just said, and I just wanted to add that it's the same for neurosurgery and the realm of neurosurgery. I mean, the whole culture it hosts as a specialty. It's much more than that. I think it's really a true life for us. And because of that, we are really honored to be part of all of this and to be able to do something or at least try to do something. So again, we are indebted to you, Rakesh, for your excellent presentation. We hope that
Thank
you
you.
will have an abundant attendance on your next one and also share more of this. And prizes will come and so on. But it's wonderful that you haven't, like put your nose up, even though you got all the prizes. I'm joking, and that you're still here. So yeah, we're all looking forward for your future successes and development. I remember when you were only going into your residency, and now you're already resident, and it's really amazing how things change
Yes.
for better with constant work. You know, it's quality in persons, and that brings bright future. So thank you for coming, and I'm really proud to be able to host this. And I would like to session for today. The next Sunday we have another session of neurosurgical Super Sunday, and I would cordially invite you all to join again in our culture. Thank you.